So what I'd like to do is I'd like to start my PowerPoint working. I'd like to start by acknowledging that I am hosting this webinar tonight from the lands of the Yugambeh language region, and I pay my respects to elders past, present and emerging. As well as paying respect, I'd also like to acknowledge the connection that we must build to improve support for Aboriginal and Torres Strait Islander people in our eczema community across Australia. And there's much more work that we know we need to do there. Before we move into the details of the webinar tonight, I just have a quick question for you, and I'd like to do that via a poll on Zoom. And it's just a quick question just to help us to gauge our current audience perspective on tonight's topic. And that's really in relation to, I guess, your understanding or whether you're actually on one of the new therapies like Dupixent or Rinvoq at the moment, or if you're interested because you feel that it could be an option for you, or even if you're another interested party, please do feel free to answer this poll question. So I'll just launch that now. Hopefully that works for everybody. And then I can share a little bit later on what sort of percentage we have of people that are already on a new therapy and who's interested in learning more. Okay, as we're going through that and answering that poll, I'd like to just outline what tonight will involve. So I'll be giving a bit of an update on Eczema Support Australia and what we're up to. And then we'll have the honour from learning about advanced eczema therapies from a leading Australian expert in this field, Dr. Gayle Ross. She'll provide us with a 20-minute presentation before we then open up the forum to questions and discussions. And that should take probably the remainder of the evening. So please do take this amazing opportunity to ask direct questions tonight. And you can do this via the Q&A button that we have on Zoom. As mentioned earlier, if you'd like your questions to be anonymous, just mention that when you put your question into the Q&A section. Only the hosts and panelists will see your question there. Now, also, I just don't want you to worry about being seen or heard tonight. Your mics and your videos are turned off. So we won't be able to see or hear whatever's happening in the background in your household, or whatever you have to deal with is fine. There may be some questions tonight, and I see a few questions that are already coming through. There may be some questions that we are not able to get to tonight due to the time or the topic. Some of the questions that we have already pre-submitted are probably more suitable for perhaps another forum or event. But if your question is not addressed tonight, we will be making contact with you so we can address those unanswered questions for you. And just one more thing, at the end of the webinar, we've got a very quick survey for you to give your feedback about the webinar and also to give us some suggestions on topics for future events. Okay, so you're welcome to continue to chat with each other through the chat option, but please do remember to place your questions in the Q&A section, and that'll be easier for me to monitor. I may not be able to keep an eye on everything going on in chat. Thank you. All right, well, I think I'll leave the poll open just for a couple more moments as people join. I see a few more people. We've got quite a good number joining. But I can give you a little bit of an update now. It looks like we've got quite a good mixture of people here. We've got quite a number already on dupilumab, a few on Rinvoq, and that makes sense because dupilumab has been PBS listed for longer. And we have about just under half that are not on a new therapy but are interested in learning more. And we also have some other interested parties here and a couple are unsure, and hopefully those who are unsure, we can perhaps shed some more light tonight on that. All right, so I'm just going to end that poll now. So hopefully we can share the results. You can see where we're at tonight. So we've got about 35% on dupilumab and 45% interested in learning more. Okay. So wonderful, thank you. Okay, so allow me to please introduce Eczema Support Australia. This is a picture of our team, and I'd like to talk a little bit about the services that we're providing as well. Eczema Support Australia was founded 7 years ago now, and we are managed by a dedicated team of volunteers, directors and project managers. What is not pictured here though are the key members of our team, and that's our eczema community. That's you. Without your engagement and involvement, we couldn't do what we do. There are a couple of other members of our team that I'd like to introduce you to tonight, and they're my twin sons, Matthew and Harry. They're the inspiration for the foundation of Eczema Support Australia. And I just wanted to share a really quick snapshot introduction to them of their story, but there's more of their story that can be seen on our website along with other life stories.
My eye has been itchy and itchy like this. Yeah. Oh, okay. Is anything to help me?
So how do we help others? It's fantastic that Matthew and Harry did receive help, and we've been able to then continue on with sharing that support that we received. Look, our vision is for all Australians living with eczema to thrive in their community and to overcome difficulties. And we do that through connection, information, and advocacy. Providing real and practical support is so important. The services that we provide include things like our support lines. We've got a 1300 eczema line that people can contact, as well as through our website and social media platforms. We've got a school kit to support children and educators, psychology support program, which is really, really important, as anybody living with eczema would understand. We've also got e-learning courses available for educators and building some for psychologists and other healthcare providers to be able to understand the impact of living with eczema. We've got a practical parenting resource for eczema families with Dr. Justin Coulson and Dr. Lauren Cundy, and connection groups and events, as well as individual and community advocacy, like the successful SOS campaign that we did to lobby government and community regarding the need for access to advanced eczema treatments like the ones we're discussing tonight. So to access these services and resources, please check out our new website. It is brand new, and hopefully it should be quite easy for you to navigate around and be able to access the services there. But for a quick summary of who we are and what we've been doing, here's another really quick clip for you.
Eczema is ranked by the World Health Organization in the top 5 non-fatal burden of disease.
Yes, you have it, but it's not who you are.
You need to get support because a chronic disease is tough and it does wear you down.
You don't realise just how much it can affect your life and every aspect of your life.
Today we are here to talk about practical parenting for eczema families.
Minimising distress will help minimise inflammation.
Through the group, Melanie launched an SOS campaign known as Save Our Skin.
In Australia, we have millions of people affected by eczema. If you need help or want to know any more information, contact Eczema Support Australia today.
Part of our mission is to provide practical and evidence-based information. And we recognise that there seemed to be a need for more information about advanced eczema therapies, and that needed to be provided directly to our eczema community. So we're extremely grateful to have Dr. Gayle Ross here tonight to give her time and expertise for us. Dr. Ross completed her Bachelor of Medicine and Bachelor of Surgery with honours from Monash University in 1999, and she was awarded the Fellowship of the Australasian College Dermatologists in 2007, gaining overall prize for having the best results. As well as consulting at East Melbourne Dermatology, Dr. Ross is visiting consultant at Royal Melbourne Hospital. She's been Director of Training for the Victorian branch of the Australasian College of Dermatologists and on the committee of the Victorian Faculty and National Training Committee. She has a special interest in atopic dermatitis, commonly referred to as eczema, and is the lead clinician at the Atopic Dermatitis Clinic at the Royal Melbourne Hospital. In light of tonight's topic, it's reassuring to know that Dr. Ross currently looks after over 100 patients on advanced therapies. So I'm so thankful to now hand over this webinar to Dr. Gayle Ross. Thank you.
Thank you, Melanie, and thank you, Eczema Support Australia, for the wonderful work that they do. So, as Melanie mentioned, I've been looking after patients with severe eczema for nearly 15 years, and it's a very exciting time to be involved because finally we have some really fantastic treatments that we can actually offer some really dramatic results. What I thought I'd do first is get some boring stuff out of the way. We know that this is a really complex condition. So it's got many factors that go into creating severe eczema, but if we understand it a little bit, we might get a better understanding of how some of these new treatments work. So we know that eczema is severe inflammation in the skin. And on the one side here, we know we've got these genetic skin barrier defects. So people with eczema just genetically don't have an intact skin barrier. And then on the other side of the equation, we've got the fact that, again, genetically, people with eczema tend to have an overactive immune system, which is overreacting to lots of normal environmental things. So we've got airborne allergies, things like dust mite, things like pollens and grasses. We've got food allergens, and we've got the microbes that live on our skin, so bacteria and viruses. So we've got this vicious cycle occurring here with all of these factors, each further disrupting the skin barrier. The bugs can get in, the immune system just gets more and more revved up, leading to this sort of extreme inflammation. So in the past, our traditional treatment has been avoidance of these triggers that we all know about. We know heat makes the skin itchy. We know the dry skin tends to flare things up, and those allergens on the skin making things worse. So we've always tried to avoid those things and repair the skin barrier with moisturizer, avoiding soap that does more damage, and keeping cool. The main treatment that everybody has been told about till the cows come home would be the cortisone creams. So while these do play an important role, for a lot of people, it just hasn't been enough. So moving on from those things, we've been able to offer light treatment or phototherapy. Sometimes people have needed bursts of prednisolone, so oral cortisone, which nobody loves giving because of the potential for side effects. And then there've also been a number of immunosuppressive treatments, so tablets like cyclosporin, azathioprine, methotrexate, and mycophenolate. So these were the things that we used to cycle people through. They had varying success. They might work for some people, but not completely. And nobody wanted to be on them long term, again, due to the risk of potential for side effects, including severe infections. So we've entered this really new, exciting era we've been waiting for years, where we now have what we call advanced therapies. So these are treatments that really specifically target the overactive part of the immune system. So the first one, dupilumab or Dupixent, which was launched in April of last year. And in April of this year, we got upadacitinib or Rinvoq. And it's good for you to be aware that there are another handful of similar treatments that are still in development that we can expect to have in the next few years. So looking at the skin, I don't want to go into this in too much detail because I know it's very complicated and very confusing. But just to look at, these are the immune cells in the skin, and they're pumping out too much of what we call cytokines. These cytokines here, interleukins 4 and 13 in particular, are just overproduced in eczema. So even in patients with normal looking skin, we can see, oh, sorry, I need to go back. We can see too many of these cytokines, and they're causing the itch, they're disrupting the barrier. And when this has been going on for a while, we'll start to see redness. So redness is the hallmark of what we see in the skin with eczema. So this is from the blood vessels being opened up to flood the skin with more immune cells. And this, again, leads to chronic changes with time, including the skin getting very thickened, which is what we call lichenification. So just so that you can see that these are our targets here, this is the target for dupilumab, so this very specific part of the immune system. But some of the other targets that are in development are things that work on, for example, this one here, TSLP, there's one coming for OX40. So there's not one particular mechanism for everyone, but we certainly have some really exciting options both here and on the horizon. So to give you an overview of the advanced therapies, I would say they're the most effective treatments we have had by a long way. So they tend to be very, very effective. And we would also say that they're considerably safer than any of the previous treatments that we've had to date, such as cyclosporin. So they are intended for long-term use. As we've seen with the video, eczema is a chronic condition. It's not something that is going to necessarily go away by itself, especially if it's been there for many years. So it needs an effective treatment that people can stay on safely for long-term use. So these treatments are now on the PBS for patients aged 12 and above. We do expect, however, in the next few years that the age of eligibility will probably come down to 6. So watch this space. So the criteria for who's eligible to go on advanced therapies, it needs to be for patients with severe eczema that's not responded to standard treatment. And the definition of standard treatment is 4 weeks of cortisone cream or one of the calcineurin inhibitor creams, which would be Elidel or tacrolimus. So you have to have failed those treatments and still be considered severe, which is an easy score. So the eczema area and severity index score needs to be greater than 20. And we'll talk about how that gets measured, and I'll show you an example of that a bit further down the track. So the criteria are based on a quality of life questionnaire that the patient fills out, and there's one for children and one for adults. And then these severity scoring tools that are done by the treating doctor, who has to either be a dermatologist or immunologist. So these are not treatments that can be prescribed by your GP. So you can have involvement either of the whole body, or if it's localized severe eczema on either hands or face, there's eligibility for those areas specifically as well. So the first treatment we'll talk about is dupilumab or Dupixent. So dupilumab blocks interleukins 4 and 13. As I said, this is not considered to be an immunosuppressive treatment. It's given as a fortnightly injection, and there's 2 doses. So the adolescent dose in the 12 to 17-year-olds is 200 milligrams once a fortnight, and in adults 18 and above, it's 300 milligrams once a fortnight. And as Melanie mentioned, I've got about 100 patients on dupilumab. And I have to say the vast majority do exceedingly well. I'd say most patients will achieve at least 75% reduction in their eczema severity. And while it might not be 100% clear, most patients would be now classified as mild or potentially clear to almost clear. And again, most patients in this group, they'd be able to significantly reduce the use of their topical creams. We see that dupilumab is very safe and it's well tolerated for most people. So very few side effects, but we'll talk about that in a minute. And the thing that I hear most when people come back and tell me how they're going is that it's life-changing. So all those simple things that you take for granted, whether it's having a shower or going for a swim, being able to sleep without waking up itching, very, very impressive improvements in quality of life. The other benefit of dupilumab is that it is also helpful for asthma. So we know a lot of people with severe eczema will have asthma as well, and you're basically able to treat that with the same injection. We've been able to get very long-lasting responses to Dupixent, and we find that the responses continue to improve with time. So it generally starts to kick in within several weeks, but we don't expect it to be at its best for some months. So it often does need patience to get to the point of really feeling like it's well controlled. The other significant benefit to Dupixent, because of how safe it is, there's no blood test monitoring required. But what's the downside? Well, in fact, there's very few. And in our patient group, we've found that only less than 5% of patients have stopped treatment. Those who have stopped, it's mainly because of this issue of allergic conjunctivitis, which occurs in around a third of patients. So people complain of their eyes being red, dry, gritty, or itchy. And it seems to be more common in people who already have a tendency to this. So we know allergic conjunctivitis, like asthma and hay fever, do run along with having severe eczema. So it is one of these things that often people have a bit of to begin with, and the dupilumab just seems to make it a little bit worse. But it's important to know it tends to be quite mild. It's not damaging to vision, so it's not something that we're really scared of. It's just a bit uncomfortable. But we can generally expect it to resolve with time and with treatment. So we get everybody to use lubricant eye drops when they start dupilumab. And if they use those regularly, most people won't have any problems. Or if they do, it tends to get better, again, with some further treatment. But we do sometimes involve the ophthalmologists to optimize people's eye care to make sure that this isn't a really ongoing, annoying problem. The other side effect that does come up a reasonable amount is this issue of a red face. So red face in people on dupilumab is not actually one condition. It's probably multiple things that we think about. The most common reason for it, I think, is actually just the underlying eczema that has not been completely switched off. So we think about that being potentially being caused by ongoing drivers behind the eczema, such as contact allergies. So this can be products that people are using, for example, fragrance or some of the plant or food-based products that people think might be suitable to be using as their moisturizer, for example, or makeup. But the other airborne things that are very hard to avoid, like pollens, grasses, and dust mite, which are just ongoing reasons why people's eczema may not be fantastic. And I think certainly face is often one of the worst affected areas by eczema, so it's going to take the longest to get better. The other reason for facial redness is a different type of dermatitis called seborrheic dermatitis. And this is actually caused by yeast overgrowth. So we all have yeast on our skin, it's allowed to be there, but at various times it'll overgrow. And again, the dupilumab seems to allow that yeast overgrowth. So when we see seborrheic dermatitis, it often is different to people's normal eczema. It tends to be a bit more sharply demarcated. It's not quite so itchy, and the areas it appears will be more brows and scalp rather than the other traditional eczema areas. And then the other red face potential diagnosis would be rosacea. So rosacea is a really common skin condition in the population, which people who have a tendency to flush will get. And if you think about that slide I showed earlier with redness in eczema being caused by the blood vessels opening up, this is effectively going to cause a bit of rosacea over the years. If you've been, getting inflammation for many, many years, it leads to the blood vessels being a bit stretched and open and red. So even when the eczema resolves, we'll still see a bit of background redness. So we need to treat what the underlying cause is. So it might be different to the standard eczema treatment, such as some anti-yeast treatment. Sometimes we need to investigate, make sure we're not missing any contact allergies, and other treatments for laser include, treatments for rosacea include laser. Other things to think about for people on dupilumab, we need to think about parasites. So interleukins 4 and 13, their role in the immune system is actually in managing parasites. So we want to check that people haven't been exposed to these before they start treatment. The most important one is a gut parasite called Strongyloides, and people can pick this up from traveling to tropical places, including Queensland. So there's a blood test for this that usually would be performed before you start dupilumab, because if you have it, you need some worm treatment before you can start the dupilumab. But we also want to make sure you're not going to pick up worms from your pets. So anybody with pets needs to ensure that they worm them regularly. The other thing to be aware of is dupilumab needs to be kept in the fridge. And this is a consideration for people who are going to be traveling for long periods of time. So they need to take their medication with them and try and keep it refrigerated. So letting their treating doctors know if they're planning to travel, because we'll provide letters to ensure the airlines, for example, will keep your medication in the fridge. We also ask any women contemplating pregnancy to discuss this with their treating doctor, because it is a complex issue and there's, an in-depth discussion needed about the pros and cons of staying on treatment. So this is one of my patients on dupilumab. He was able to receive access to it. We had a handful of patients who got compassionate access back in 2018. So you can see the damage that was being done to his skin from the severe itch and scratching. And within 3 months of commencing dupilumab, his skin had essentially healed. So it does take time for all that redness and all those marks to fade. But essentially he stayed on treatment and is almost eczema free. So from a baseline EASI score of 32, so if you remember, severe is classified as over 20. From a score of 32, he's come down to, in May this year, 0.3. So not 100%, but this is an extremely good result. Very, very happy patient, has never had a normal life until now and can now work and function for the first time ever. This is another one of my patients who received access back in 2018. And you can see again, within 6 months, really significant improvements in his eczema. But as you can imagine, the severity of that eczema on his face on the left-hand side, it does take time for it all to settle down. So people need to, again, when it's been going for many, many years, not expected to be gone within days to weeks. It's more like months. So again, his baseline EASI score was 40. And when I saw him recently, he's been down under 3. So another really fantastic response. So demonstrating these patients, because they've been on it for a long time, it gives you some reassurance that we really do expect the eczema to remain very well controlled with ongoing treatment. So we'll move on now to upadacitinib, or Rinvoq. So this is a medication which is called a Janus kinase inhibitor. So it's working in a slightly different way to dupilumab. It actually blocks multiple cytokines, but not completely. So it's considered mildly immunosuppressive, but not as much as our previous old-fashioned treatments like cyclosporin. But this one's given as a daily tablet. But because it's relatively new to come onto the PBS, I don't have as much experience with it, only a handful of patients. So the benefits of Rinvoq would be, it certainly works very quickly. Most people will notice a difference within days. So it'll switch that itch off very nicely. And in the study, certainly more patients on Rinvoq would achieve a greater skin clearance than with dupilumab. But I think we still need some more time and real world experience to know whether this is in fact a sustained benefit. So for a lot of people who don't like the idea of injections, said it is a tablet. And we do have 2 doses available with Rinvoq, which is quite nice. So we've got the option to increase the dose from the baseline starting dose of 15 milligrams up to 30 milligrams if that's needed. So Rinvoq is also used to treat a few other conditions, including various forms of inflammatory arthritis, like rheumatoid arthritis. There's a type of autoimmune hair loss called alopecia areata that it also is useful for. So if people have those as underlying conditions, then potentially Rinvoq would be a better treatment option than dupilumab. And the other benefit is that it doesn't have the eye side effects. So again, for people with a history of severe underlying eye disease who would be nervous about dupilumab, Rinvoq would potentially offer a nice alternative. So the risks of Rinvoq, the most common side effect seen is actually acne. And this is usually relatively mild. And as dermatologists, we're pretty good at treating it. So it's not a big concern. The thing that we are most concerned about is infections. So there is a higher risk of herpes infections and shingles with Rinvoq, but also potentially coughs and colds. And in fact, these are the main reasons why people might potentially cease treatment. And a few of my patients starting have in fact had to cease already because of severe episodes of both herpes and shingles. So for people with severe history of herpes already, again, maybe not the right treatment for you. There's potentially a small increased risk of blood clots. So again, people with a past history of blood clots, so DVTs, might wish to not go on this treatment. And we do need to monitor blood tests. So while it's a tablet, it's not an injection, there's still needles involved because there's regular blood tests required. So we need to check people's blood count, their liver function, and their cholesterol, because those things can sometimes be affected. The other considerations with Rinvoq, so we want everybody to have all the vaccinations they possibly can to make sure they're not going to get infections. So the shingles vaccine is particularly important, and it is a little bit of a tricky issue. There's 2 shingles vaccines available. The new effective one called Shingrix, it's just unfortunately very expensive. It's over $400. So this can be a bit of a barrier. But the alternative shingles vaccine called Zostavax is actually a live vaccine, and people already on Rinvoq are not allowed to receive live vaccines. They would have to stop the treatment or potentially delay the treatment to be completely vaccinated before they start. And we do also advise that if people become unwell with infections, so colds, flus, and COVID, for example, they would temporarily need to stop treatment until they recover and then can restart it. And this just comes with a potential risk that the eczema will flare up. So this is an example of one of my patients on Rinvoq, and it also gives you an example of that easy score that we were talking about, which is one of the scoring tools that would be done by your treating doctor every time you're seen to get a feel for where your eczema is and how you would potentially be responding to treatment. So it's based on how much redness, how bumpy or raised the skin is, how many scratch marks, how much thickening, that's the chronic changes of eczema, and the surface area that's involved, and then for each body region, so head, trunk, upper limbs, lower limbs, and it's an algorithm that spits out a number. So you can see that at the start of January 2021, this patient had an easy score of 34, and he was grumbling around in this area as we didn't have any fantastic treatments, and he was a bit nervous about dupilumab because of quite severe pre-existing eye problems. So back in middle of 2021, we actually were able to get him onto treatment with baricitinib, which is a different JAK inhibitor because we didn't have access to Rinvoq yet. So he started baricitinib and his eczema easy score improved down to 7. So this was quite a nice response. However, it soon became clear that baricitinib was not going to achieve PBS approval. And so we weren't going to be able to continue to supply baricitinib to patients anymore. But fortunately, around this time, we got approval for Rinvoq. So the patient switched over to Rinvoq. And you can see that his score continued to actually come down from 7 down to 4. And then when he was seen just a few weeks ago, down to 2. So basically anything under 10 is good, but the lower the better. So an easy score of 2 is minimal eczema. And this patient was, really very, very happy and was not having any problems from it. So that is where I will stop, and we can move on to some questions.
Wow, thank you so much, Dr. Ross. It was a really, really informative presentation. There was so much information in there, and I just want to reassure everyone listening that if you want to catch up on the information, we will have a recording of this webinar available for you. Some of the questions that we have coming through, and also pre-submitted questions, probably covering some of that information again, but I think they're still worth asking because there are some questions that may not have been covered. So I'd like to just start with some of the pre-submitted questions before we move on to those live questions on there. And I know that some people have asked in the live and pre-submitted, so they're really keen to get the answers on these. For example, we've got a few people actually that have asked. Louise, Yang, Emma asked about the duration for Dupixent or Rinvoq treatment. How long can you be on it for? How long should you be on it for?
So the idea with these treatments is that you stay on them long term. So there is no stop date. We don't consider that it becomes a problem to stay on them at any point. So we know that it's likely that the eczema will come back if the treatment is stopped, because we unable, unfortunately, this is not gene therapy, we're not able to change people's genetic tendencies. So while we are switching off the disease, it's only going to last while you stay on the treatment. So the answer is stay on it. However, there's always the possibility, if the eczema has stayed clear for a long, long time, well, we're going to ask the question, is it still needed? And there's the possibilities that we can either stretch out treatment doses or even potentially lower doses to see what would happen, because not everybody's eczema will come back. And I have hopes that potentially the younger age range, we might actually be modifying their immune system in a good way going forward, that they won't necessarily go back to being severe again, even when the treatment stops. So I said early days to be able to give a definitive answer on that, but the aim is stay on your treatment.
And that's the answer to my next question was going to be, one of our live questions was, once the skin has healed, do they stay on a maintenance dose of these drugs? And I think you've answered that quite well.
Yeah.
A specific question here, which I guess is a little bit related, but not, is in relation to, does these drugs, they deal with the itch and inflammation, but can allergic responses and hives still exist? So in other words, is it just masking some of the symptoms, but they're still having an allergic reaction at times?
No, it's not masking. It's actually, I said, switching it off and treating it. But some allergic reactions are working on a different pathway, a different mechanism. So for example, anaphylaxis, totally different reaction. That's not eczema. So can somebody on dupilumab still have anaphylaxis? Absolutely. So it wouldn't hide that. It's not like you're going to miss an allergic reaction. The same reactions are probably still going to happen.
I will go to a couple more live questions in a minute, but one of the questions that came through quite often in the pre-submitted questions was around the long-term safety, and in particular, I'll just read out actually one that came through pre-submitted and live from, just find it from Jay's. She's tried to do some research herself. She's a mother of an eczema sufferer and a health professional herself. She's been able to look at efficiency, safety data for up to 52 weeks, but not beyond that. Do you have any insight into some longer term studies?
Yeah, absolutely.
On Dupixent and Rinvoq?
Yeah. So, I mean, all the published studies, those are the kind of the landmark trials that got these medications to be approved, but we absolutely do have longer data than that through registries and things, but it might not be so easy for people to find. But yeah, our experience is that there are no new safety concerns that have appeared. So remember, these drugs have actually been in use in the US and Europe for 3 or 4 years now. So Australia gets everything quite late. So it's partly our PBS system is one of the strictest in the world. So you can be reassured that if something is approved in Australia, it's because they really made sure it's safe and everybody else around the world has tested it out first. So while we always feel disappointed that we don't get these things quickly enough, it really does ensure that it's quite safe. So yeah, we really don't have any new concerns that have emerged in the years that people have been using it.
A question that I have from, can't get the name right now, I should have put this in bigger typo for myself. Someone's asked about which one should they be on? How do they decide whether they should be on Dupixent or Rinvoq? Is it due to comorbidities, or what are the factors that make the decision?
So look, I think this is an individual discussion that people need to have with their treating doctor. So there's lots of things that need to be considered. So I always think, safety is paramount. And if you're comparing the two medications, I would say that dupilumab is the safer choice. So it would be my first preference if everything else was equal. So for example, if you're a patient who just has eczema and, nothing else going on, you don't have severe eye disease, I would say go for dupilumab. However, if you've got these other, comorbidities that we've mentioned, like arthritis or alopecia, or you've got really bad pre-existing eye disease, then I would say think about Rinvoq. The other things to make me think about dupilumab in preference would be, as I said, asthma, because it will work for that as well. If people have really bad episodes of herpes infections, again, I'd go dupilumab. We can give dupilumab to people who have other cancers, for example. So I've got a patient who's got a metastatic cancer and he wouldn't be allowed to go on Rinvoq, but because dupilumab, is really very safe, he can certainly take that. So these are some of the considerations that we take into account. There's also the whole injection versus tablet debate. And while I know
a lot of questions around
that this does worry lots of people, but even people who are terribly afraid of needles will actually get used to dupilumab pretty quickly and find that it's not very difficult. And, there's a lot of support out there to help. There's the patient support program and nurses who can assist with this. And I actually think it's easier to do a fortnightly injection sometimes than remember a daily tablet. And also because it lasts for longer, often if you stop, it's not going to flare up as quickly. Whereas if you stop Rinvoq, because it works very quickly, it also stops working quite quickly. So sometimes that's a bad thing, because if you miss a few days, you're going to flare up. Sometimes that's a good thing if you're having a side effect or an infection. If you stop, it's going to stop working quickly. So again, there's sort of pros and cons to both. But I would say, first line dupilumab.
And I know someone was asking, Cassie was asking about with dupilumab with the injection, do many people stretch it out to more than 2 weeks?
Look, I think it does happen. Is that something that we necessarily encourage people to do? No, but often people can get away with it as without necessarily flaring up straight away. But there are also some people who will notice when they're due for their injection, they feel like it's starting to creep back. So both sides of the coin.
Yeah. Okay. We have a number of questions around children, and particularly young children and babies. And I just wanted to read one of the live questions out here from Jenna. She said, treatment options for very young babies is severe eczema. She's got a 9-week-old baby, currently wet wrapping, bleach baths, steroids, 10 times a day moisturising. Already 9-week-old baby, already 2 hospital admissions so far, not much success in keeping it under control. And someone else has asked too, what are the options for very young children now and into the future?
Yeah, look, unfortunately, these advanced therapies are not available for that age group. As I said, it's at this stage 12 plus. And this is because, nobody does trials in that very young age group. It's very difficult to conduct trials on children and babies. Nobody wants to cause harm, and it's just one of these things that it has to come down the ages with time. But I think the other reason why it's not available is that there's the thought that most young children with eczema will grow out of it. We say, 80% will grow out of it by the age of 8, which is quite a long time. And we know a lot of people won't, but the hope is that people won't need these treatments if they do the standard treatments, and then hopefully they will improve. So, my hope for that person on the call will be, there will be some other options for that baby, and it won't necessarily be a lifelong issue, but, we should have other options for them.
Yeah, absolutely. And just another specific, I know you've addressed the eye issue in quite detail, but I have a specific question here about vision. Kobe said that her vision's actually worsened, particularly in the eye, that the flare-ups are happening more, seems to be the actual vision is worsening. Is that a direct link, or what's your understanding there of vision?
Very, very hard to know in each, individual case. It might just be if the eye is very watery, then that's going to make the vision a bit blurry. So it might not be, as I said, an actual visual change, but just it looks a bit different through that watery eye. But I would just encourage them to get that eye checked. And maybe it's she does need glasses and that eye is, different, but we don't think that that's going to be, directly the dupilumab.
Yeah. I know I'm not on dupilumab myself, but I know my own vision, just my age, it seems to be every week getting worse at the moment. That age, unfortunately. I'll just pop through some other, I know we've had a few more live questions come through as I've been chatting. Yes. Again, I know that you've touched on this in your presentation, but your thoughts on falling pregnant while on Dupixent, dupilumab, and another question as well from, I think it's Angela, about breastfeeding while on dupilumab. So I guess 2 separate questions there.
Yeah. So I said, this is a difficult question, and we could probably talk for half an hour on the subject. The issue, again, like testing new medications on children, studies are not done in women who are allowed to get pregnant. So basically, all women on clinical trials have to be on, effective forms of contraception. So it's not until medications often get into the community and the real world happens, which is that people fall pregnant, that we start to get an understanding of what potentially could happen in pregnancy. So the pregnancies that have occurred worldwide so far in dupilumab, there doesn't seem to be a higher risk, and there have been successful pregnancies. but we just really don't have enough information. It hasn't been really around for long enough for us to be confident that we can say, yes, you can stay on it and get pregnant. But at the same time, we would be relatively confident it would be okay. But I said, is it worth the risk? It's an individual decision. But we know some people, if their eczema is so severe off dupilumab, then that would be more of a risk to the patient and to the pregnancy than potentially the medication. So I said, it's always this weighing up, what's the risk, what's the benefit? So something to discuss with the treating doctor. In terms of breastfeeding, so because this is effectively an antibody medication, hence why it has to be given as an injection. If it's given orally, it gets degraded by the stomach. So it doesn't actually get into your system through the stomach. So while it does get into breast milk, when the baby drinks that milk, the antibody in their stomach would get degraded. So we don't expect that the baby would be getting any significant medication through the breast milk. So it is something, again, it's not something that the product information says, yes, it's safe to breastfeed, but we would expect that it would be a low risk thing to do.
Terrific, thank you. That answers that really well. And you're talking before about the fact that it's injected, and that's the reasons why it operates that way. One of the questions we had tonight was, is there any chance that dupilumab would be developed into an oral tablet?
No, unfortunately, it just would not work that way. But in terms of pain of the injections, I know there's a question about this. One of the tips for minimizing pain with injections is to make sure you've left it out of the fridge for long enough to come to room temperature, so 45 minutes to an hour. If it's at room temperature, it's easier to inject. It's not as solid, so pain is a bit less. There's also a few sort of injection techniques. I think for very slim people who don't have a lot of body fat, it can be a little bit more painful because we're trying to get it into the fat layer, and some people don't have that, unfortunately. But there's also potentially a new pen device being developed, which I think will be a little bit easier for people to use.
Yeah. And I hope it's okay for me to share a little bit here. My two boys, 13 years old, are on dupilumab. One started back in September, so it's been on it for a while, and one more recently. And just, I guess, some reassurance for people out there. The one who started in September, he's really coping well with the injections now. The one who started more recently, he's still getting used to them. So it does take time, I think, for some, and they don't have a lot of subcutaneous fat either, and that's one of the struggles we have, is because we know the fluid's got to go somewhere and absorb.
Yeah. Just compare it to other conditions. You know, I think of those poor diabetics out there who are injecting 4 times a day, once a fortnight. I think, you know, it's not the end of the world.
I have a specific question here, and I know we talked about it's dupilumab and Rinvoq are not currently PBS listed for under 12, but I am aware that there are some very, very young children who are on these treatments, and I've got one question here specifically from Emma, who says her 3-year-old has just started with dupilumab. He's had his second injection on Friday. He's having adult dosage for every 4 weeks. I'm aware that that is a recommended dose for families. Should I be concerned he's having high dosage, she's asking?
It wouldn't be, because it's once a month.
Yeah, so no concerns there. Terrific. And some questions about Rinvoq. How long after the live vaccine, Zostavax vaccine, can one start Rinvoq?
Again, that's quite a tricky question. I think it's probably a month or 2, but I would need to double check.
Okay. How often do you need to deworm yourself when on Dupixent? It's a good question, actually.
If you don't have pets, not very often, I said I would just deworm the pets. But if you really want to deworm yourself as well, just to be on the safe side, once or twice a year. But I said, if you travel to Queensland, I like to know about that and recheck the strongyloides blood test.
And another live question here. We've got someone who's 35 years of severe eczema, qualified for dupilumab last year, but couldn't start until she completed 6 months treatment for latent TB, tuberculosis. TB was found during screening for dupilumab. First winter eczema has cleared up and no longer qualify for the treatment. Is there a connection between TB treatment drugs and eczema healing?
No, but eczema does this. It goes up and down, and it's going to have good months and bad months. If you've had severe eczema in the past, it will probably become severe again at some stage, and I'm sure you'll requalify.
So, yeah, please just stay in contact with your health specialist.
Exactly. So at the first sign of it flaring up, go back and see them and get onto it.
Okay, I'm just checking to see if we've missed any questions that we haven't covered before. Here's a question I think we answer fairly quickly. Is there any knowledge of when a GP might be able to prescribe the new advanced treatments?
They won't be able to. No. That's just the PBS requirement. So basically your GP needs to refer you to a dermatologist or a clinical immunologist.
Yeah. Okay. All right. Okay, you mentioned about having to stop Rinvoq if you are sick with the, I guess, the virus and fevers.
Yep.
And Jade asked, why do you have to stop when sick? Does it react with antibiotics specifically?
No, it's just that if your immune system's a bit down, you could become more sick. So we just want to give your immune system a chance to recover from whatever infection you have.
Excellent. Okay. I know that we're coming to 9 o'clock now and we need to start wrapping up. And I know we have got some other questions that may not have been answered in full, but if you do have other questions that haven't been answered, and particularly if they're not specifically about the new emerging treatments, we will get back to you. We will address those unanswered questions for you with help of expert assistance, obviously, with qualified advice. But I'd like to thank you so much, Dr. Ross, for being so patient with all of our many, many questions. And hopefully we can continue this conversation offline as need be. So just be patient with me a little bit more, everyone. I just got a few more things that I just want to go through. So if you don't mind, I will share my screen again. And okay, move on to that. Okay. Sorry, I'll hear that, see that, I hope. Okay, so I just wanted to let you know what's next. Well, as I mentioned earlier, there will be a recording of this webinar for you to access later on. We do have a quick survey after this that I'd encourage you to complete for us to give us feedback and suggestions on other topics. I'd just like to let you know quickly about our next events. We have an event coming up specifically for families. If you're overwhelmed with eczema, this is a peer support event for you to join and participate in, and we can share that support with you. And we're very excited to be able to let you know about a teen event we've got coming up and some more information about this. We have got a new platform we're about to launch for teenagers specifically, because we recognise they do need more connection and support than they are getting at the moment. And so please stay tuned for that. We'll send that information out very soon. And we have World Atopic Eczema Day coming up on the 14th of September. And I'm asking for you to also keep your eye out for information about that, because we'd really like you to get involved in that. The theme this year is Inside Atopic Eczema, recognising the burdens of atopic eczema. It's not just a surface condition. There are many factors that impact life with eczema. And we're going to be displaying that through wearing our clothes inside out, sharing photos and sharing stories a little bit more. So please get involved when you get that information through. We have a website there, and there are many different ways to get involved. We really do need your support and engagement to continue our work. We are a small and dedicated team that relies on the support of our eczema community. We're not a government-funded entity with ongoing funds, so please head over to the website, see how you might be able to get involved. There are many ways to give, and they're not all financial. And if you need assistance yourself, please reach out to us. So again, I'd like to say thank you so much, Dr. Ross, for your expert information, and I hope everyone's had a good evening tonight. Don't forget to stay connected, and please do complete the survey. Thank you.
Good night, everybody. See you.
Good night. Oh, and for those still listening, I'm very sorry about the chat function not working earlier, but I think we did get that working. So hopefully a few of you got to chat, and we'll get connected in other ways.